Good afternoon, everyone. I am Amy Hajari Case. I am a Senior Medical Advisor at the Pulmonary Fibrosis Foundation, and I'd like to welcome all of you to our industry-sponsored webinar this afternoon. This is the second in a series on pulmonary hypertension associated with interstitial lung disease. And so we're excited to be back after a great discussion at our last webinar. So we'll just continue our topic today with our wonderful presenters are back again with us. Thank you both for being here. I'll introduce them both. Dr. Hyun Kim is the director of the Interstitial Lung Disease Program and Pulmonary Fibrosis Foundation Care Center Network site, and she supervises the ILD clinical trials at the University of Minnesota. Her clinical expertise centers on treating patients with ILD, and her research interests are in the natural history and outcomes in IPF, pharmacogenomics of antifibrotic medications, non-pharmacologic treatments for ILD, and clinical trials in ILD. And we also have with us again Dr. Thenappan. He's an associate professor of medicine in the cardiovascular division and a clinical research scholar at the University of Minnesota. He's interested in translational research in pulmonary vascular disease, and his current research focuses on developing novel therapies for right ventricular failure secondary to pulmonary vascular disease. And he's published on pulmonary vascular disease and right ventricular function in multiple high-impact journals. He's a member of the American Heart Association, American Thoracic Society, Pulmonary Vascular Research Institute, and Pulmonary Hypertension Association. So thank you both again for being here. Just a couple of housekeeping items before we get started with our topic. If you are unfamiliar with the GoToWebinar platform or just need a little refresher, there should be a control panel to the right side of your screen. If you are looking for our slides for today, we do have them to download from a handout tab that's on that control panel. If you go almost all the way to the bottom of the control panel, there's a little drop-down menu that says handouts. If you click on the link there, you should be able to download those in PDF format if you'd like to follow along or look at them later. Below that is a chat drop-down. If you're having any technical issues or problems, a member of our staff will be watching that chat box to try to help you with any problems you may be having with the platform. And if you have any questions as they come up during the webinar today, we will try to get to as many of those as we can at the end of our session. So please go to the questions tab, which is a little up from the handouts and chat. Drop that down and submit your questions there. And as I said, we'll get to as many of them as we can today on the topic of the diagnosis of pulmonary hypertension related to interstitial lung disease. So these are the disclosures for our panel today. And with that, I will turn things over to Dr. Kim and Dr. Thenappan. Thank you both again for being here.
Thank you, Dr. Case. As Dr. Case mentioned, I'm Hyun Kim at the University of Minnesota, and I will say that Dr. Thenappan and I did part one of this webinar about a month and a half ago, and we just thought it was wonderful. We both actually had a really nice time, and hopefully many of you were able to view that webinar and found it educational. So just a disclaimer, what we talk about today is really informational. It's to provide education for all of you, and whether you're a patient or a caregiver or family or friend, this doesn't necessarily apply to your specific situation. So if you have questions or concerns, please see or contact your medical provider. We were talking in generalities about interstitial lung disease and pulmonary hypertension. We do not want to substitute what we're saying for your specific situation, but we hope that we can shed some light on both interstitial lung disease and pulmonary hypertension, and that coexistence or that overlap between the two processes. Next slide, please. So we'll start just with a brief overview of what we talked about in webinar one, which is what is pulmonary hypertension and interstitial lung disease. And from here on in, I will talk about pulmonary hypertension as PH and interstitial lung disease as ILD. I'll go over a little bit about how what ILD is and how it affects the lungs and how PH-ILD is diagnosed. And Dr. Thenappan will also talk in more detail about some of the testing for PH-ILD and how it's monitored. And then he and I will have a joint sort of back and forth discussion about how we collaborate, and then we'll answer it up to open up the session to questions. Next slide, please. So what is PH-ILD? Next slide, please. So I'm going to talk a little bit about anatomy, and I will try to condense what I know about anatomy into a few minutes. And it took me years to learn this. So we can think about the heart and the lungs as forming a circuit, with the blood vessels being the conduit, the conduits in the circuit. So if you look at this schematic, you'll see on your bottom right, it says blood from the body. So blood from the body comes back to the heart. And the reason this blood looks blue is because there's very little oxygen. The oxygen has been absorbed by the body or used by the body. So deoxygenated blood, which is blue blood, comes back to the heart, to the right side of the heart. And if you follow the arrow, you see blood from the body. That blood is flowing back to the right side of the heart. The heart then pumps that blood to the lungs. And you can see if you follow the arrows, blood goes from the body to the right atrium, and the heart pumps blood to the lungs. And you follow the blue blood and the arrows. So the blood gets pumped from the heart through the pulmonary arteries into the lungs. And what the lungs do is very important, and it's such a cool organ. As you know, we breathe in the air, and in the air is oxygen. And our bodies need oxygen in order to survive and thrive and do their function and do our functions. So the air that we breathe in travels through our windpipe, the trachea. And I always tell my patients to think of the lungs and the airways as an upside down tree. So the lungs at the top of your diagram, at the top of the drawing, sort of looks like an upside down tree, right? There's the one tube, which is the trachea or the windpipe. We breathe in the air. It comes through our nose or mouth, down through the trachea and into the lungs. We have a right lung and a left lung. So the trachea or windpipe is like the trunk of the tree. The trunk, if you recall, then branches, and those branches branch, and those branches branch until you get the very, very small twigs. And on the end of the twigs are the leaves, right? So if you think of the lungs, the trunk is the trachea or windpipe. The trachea then branches to the main bronchus to the right lung and the main bronchus to the left lung, and those bronchi then branch and branch and branch. And at the end of the very, very small airways or bronchioles are the leaves or air sacs, and those are called alveoli. So what you notice is blood comes from the body to the right atrium or right side of the heart, gets pumped to the lungs through the pulmonary arteries, and sort of circulates through the lungs. And what happens is we breathe in the air goes through the trachea or windpipe, through all the small branches to the very, very ends, which is the air sacs or alveoli, and that's where the heavy duty work happens. The oxygen, when it reaches the alveoli, then gets absorbed through a very small, very thin barrier from the air in the lungs through this barrier, which is very thin, into the blood in the pulmonary arteries. The oxygen then gets absorbed and sort of oxygenates the blood and turns red, meaning that oxygen is absorbed. And does it actually turn red? Yes, because oxygenated blood appears red. And then the oxygenated blood goes through the lungs and back to the heart, the left side of the heart. The left side of the heart pumps that red oxygenated blood then to the rest of the body. So it is a circuit, it's a loop, and the heart and the lungs work very closely together. The job of the lungs is to breathe in the oxygen, the air and the oxygen, and then absorb the oxygen into the bloodstream. And we're going to talk today a little bit about interstitial lung disease, and then what happens to those pulmonary arteries that bring the blood to the lungs from the heart. Okay, next slide, please. So what is interstitial lung disease? This is a definition from the Mayo Clinic. What I tell my patients is, think of interstitial lung disease as one big, broad category. It is not one specific disease or process. There are hundreds of different types of interstitial lung disease. But the characteristic of all the diseases or processes in this broad category of ILD is that there is inflammation and/or scarring of the lungs. Scarring of the lungs is called pulmonary fibrosis. Next slide, please. So how does ILD affect the lungs? When you have pulmonary fibrosis or scarring in the lungs, that scar is permanent. So think of, for example, when you get a cut on your skin or something happens that develops into a scar, right? That scar on the skin is made up of collagen, which is the scar tissue, and that scar is permanent. A similar process happens in pulmonary fibrosis. There is an insult or injury or inflammation to the lungs, and over time that develops into scarring, and that scar tissue in the lungs is very similar or the same as the scar on your skin. It's made up of collagen. As we look at a scar in the skin, that's how we look at scar in the lungs. Pulmonary fibrosis is permanent. Once the lung scars, it's very difficult to minimize or reverse it. In fact, we don't currently have therapy that will reverse or melt scar in the lungs or anywhere in the body. That is the holy grail, though. There's a lot of research, as you can imagine, in trying to figure out how to reverse pulmonary fibrosis. But as we develop scar in the lungs, sometimes that scar thickens the barrier between the air sac and the blood vessel. So as I alluded to, the oxygen in the air in the lung from the air sac has to be absorbed. So it diffuses through that barrier between the air sac and the blood vessel. That barrier, or that space in the lung, is called the interstitium, and that's why we call it interstitial lung disease. The scar tissue tends to form in that interstitium, and it increases the thickness of that barrier that the oxygen has to diffuse through. Because of that, it takes longer for the lungs to absorb the oxygen, and oxygen levels can decline. And when that happens, it can cause shortness of breath, particularly with activity, whether it's walking or exercising or just daily activities, going to the store, for example. So this is why people with interstitial lung disease and pulmonary fibrosis develop low oxygen levels and feel short of breath. Next slide, please.
Yeah, thank you, Dr. Kim. I'll just take it from here for a few slides. My name is Thenappan. I'm a cardiologist here at the University of Minnesota. I work with Dr. Kim closely in taking care of patients with pulmonary hypertension due to interstitial lung disease, and it's my pleasure to join you all. So to continue with our discussion, how does pulmonary hypertension affects the blood vessels in the lungs? So basically, it's a disease of the blood vessels in the lungs. Like Dr. Kim very nicely summarized how interstitial lung disease affects the lungs, but after some time, this interstitial lung disease will also affect the blood vessels that's running in the lungs. So in people who don't have pulmonary hypertension of any sort, blood vessels in the lungs are open, wide, and it allows the blood to come from the right side of the heart to the left side of the heart. But what happens is in some patients, these blood vessels in the lungs get thickened, as you can see in the picture here, like in the middle, like the circle to your right. The blood vessel is actually thick. The pink color is the blood vessel wall, and you can see how thick it is compared to the picture on the left-hand side, where the pink color is very, very thin. So when the blood vessel gets thick, there is less space for the blood to flow. So it's like your kitchen sink. When your kitchen sink, like drainage tube, gets blocked, there is less space for the water to drain. like that, the blood vessels can get thicker, and when it gets thicker, there is less space for the blood to flow. So what happens is, if there is less space for the blood to flow, the pressure inside the blood vessels increases. So it's like traffic jam. There is less space, more blood is trying to go there, so the pressure builds up high. So this is what happens when pulmonary hypertension affects the blood vessels in the lungs. Next slide, please. Okay, how does the pulmonary hypertension affects the lungs? In two ways. Number one, the blood vessels are getting thicker. So as Dr. Kim explained, when you have interstitial lung disease, the lung parenchyma, like the lung tissue through which the oxygen gets into the body from the air we breathe in, gets thicker. So when the lung tissue gets thicker, it's harder for the oxygen to get from the air we breathe into the blood. On top of that, if the blood vessels are also thicker, it's really difficult for the oxygen to get into our body. So when we breathe in, the oxygen will go into the lungs, and from the lungs, it gets into the blood vessels. So if the lungs have a thick wall, and the blood vessels also get thicker and have a thick wall, the oxygen finds it difficult to diffuse from the lungs through these thick walls into the blood. So you get less oxygen. So when you have interstitial lung disease, to begin with, you have low oxygen. And when you develop pulmonary hypertension, or when the patient develops pulmonary hypertension, the oxygen level even drops further. That's number one. Number two, the second way in which it can affect the heart and the lungs is when the blood vessels get smaller, the pressure builds up. So the right side of the heart is the one that pumps the blood into these blood vessels, and the pressure builds up. The right side of the heart has to work really harder. So it works hard, and at some point, the heart gets enlarged, and it can eventually fail over time, calling as a right heart failure. Next slide, please. So how does an interstitial lung disease progress to pulmonary hypertension into interstitial lung disease? So let's just start with the picture to your left. So pulmonary fibrosis, or IPF, causes lung scarring. So basically there is scar tissue that's in the lung blocks. When there is scar in the lung blocks, it's difficult for the oxygen to move from the air we breathe in into the bloodstream. But over time, what happens is the scar tissue starts to affect the blood vessels, and the blood vessel gets thicker. So that's the middle circle panel. You can see how a healthy blood vessels is in the top, where you see a lot of red blood that's flowing. But in the bottom half of that circle, you see the blood vessel is really thick now, and the amount of blood that's flowing becomes very, very less. And this thickening happens due to multiple mechanisms. One is just the low oxygen level itself will make the blood vessels in the lungs to get thicker. We also believe that the scar tissue itself can go and damage the blood vessels, so there is less blood vessels to flow. Those are the two reasons why we feel. And there are also other mechanisms that's being explored to better understand why the blood vessel gets thick. So when the blood vessel gets thick, like we talked about, what happens is the oxygen level falls even further down, and that's adding more fuel to the fire. It's a feedback loop. It just goes in circles. So low oxygen level, blood vessel gets thicker, oxygen level drops further. That makes the oxygen to drop even further, blood vessel gets thicker. So it goes in vicious circle. So then what happens is this starts to affect the right side of the heart, because when the pressure builds up, the right side of the heart has to work really harder. And when that happens, your heart gets enlarged and it fails to pump enough blood. And that's the panel on your right-hand side circle showing it affects the heart. So if I have to summarize, how does ILD progress to pulmonary hypertension? ILD, low oxygen level and tissue causes damage to the blood vessels, and the blood vessel gets thicker. When the blood vessel gets thicker, the pressure inside goes up. That makes the oxygen level even lower and also affects the heart. Next slide, please. So how do we diagnose pulmonary hypertension in patients with interstitial lung disease? I'll have Dr. Kim go over the initial steps, and then I'll join back later. And next slide, please.
So, thank you, Dr. Thenappan. So, as Dr. Thenappan mentioned, both pulmonary hypertension and ILD can cause damage to the lungs. And when you have both processes, the damage to the lungs gets amplified, and then the heart gets affected, and the heart has to pump harder and harder to pump the blood through the narrow vessels, through the scarred lungs. And so when we are caring for our patients with ILD, we're always aware of pulmonary hypertension as a possible development. And for example, when we talk to our patients with ILD, sometimes you might say, well, my doctor asks me the same questions at every visit. And it's not because we're boring people, it's because we're asking you these questions because this is how we can tell, number one, how's your ILD doing? Number two, how are you feeling? And number three, if your symptoms are changing, that could be a tip-off that either your ILD is changing or you might be developing pulmonary hypertension. And the other reason we think about pulmonary hypertension as a possibility in ILD is that it can complicate management of the ILD and the pH and can sometimes impact life expectancy. So we're always thinking about pH as a possibility, and we focus firstly on how you're feeling and what are your symptoms, because that can really help us to determine if now we have, now we should screen for pH, or now we should do some testing. Next slide, please. So screening for pH. So what specifically are we talking about? So if you have ILD, if you know someone with ILD, you know that the common symptoms are shortness of breath, especially with activity or movement, cough, and sometimes fatigue. If ILD worsens, if medications aren't working, sometimes those symptoms can get worse over time. The confusing thing is that pulmonary hypertension can cause very similar symptoms: shortness of breath, cough, and fatigue. I think the one difference is dizziness, lightheadedness, or fainting. So I always ask my patients about fainting, especially when they first come to see me, or if their symptoms are changing. And so for some patients, they might be a little bit confused. Why is my doctor asking me if I faint? And it's one of the things that we look for as a clue that, that maybe pH is developing. So because symptoms are very similar, we focus on the specific symptoms of shortness of breath, cough, and energy. If someone says my energy is just low, I don't feel like I have the energy to do the things I used to be able to do, that could be a tip-off. It could be either ILD is getting worse, or maybe something else is happening like pulmonary hypertension. So for some patients with ILD, especially some of our scleroderma patients, we'll screen at the time of diagnosis, perhaps even before there are any symptoms, just because it's a very known high risk for pulmonary hypertension. But for many of our ILD patients, we really focus on how are you feeling? How are your symptoms doing? So the first step is symptoms. How are you doing? How are your symptoms doing? It's very difficult just to use the physical exam to pick up pulmonary hypertension. One, because our ears aren't that good, but two, by the time the physical exam changes, then it might be too late. Next slide, please. So what are some of the tests we use that suggest the presence of pulmonary hypertension? Next slide, please. So we look for specific indicators that suggest pulmonary hypertension. It can be progressive, just like ILD can be progressive. And so we want to make sure that if we suspect pulmonary hypertension, we're going to do some specific tests. Next slide, please. So one of the first tests we do is pulmonary function test, or PFT. So as you all know, PFT is very commonly done in patients with ILD. In fact, every visit we try to do a PFT. I know it's hard. It makes you cough. It makes you more short of breath. Sometimes it makes you feel a little dizzy. And some of my patients say, you know, they hate it, but they also know that it is a test that they have to do every day. In people with ILD, we know that the PFT gives us very useful information. So interesting thing about PFT is it can also give us useful information about pulmonary hypertension. So in a pulmonary function test, you take a deep breath in and you blow out all the air. And what the PFT lab tech and the PFT machine is doing is it's measuring the volume of air that you're blowing out. And that's a way for us to measure lung capacity or lung function. How much air can your lungs hold? The other test you do sometimes is the DLCO, the diffusing capacity, and that's very useful to us, both for ILD but also for pulmonary hypertension. This is the test where you have to pant. You know, you're sitting in the box, they put this tube in your mouth and you go, they pant, and it's a way of measuring diffusing capacity. That measures how well your your lungs absorb the oxygen from the air that you're breathing in. And as we talked about, for ILD, that drops. For patients with ILD, the diffusing capacity drops because your lungs don't absorb as much oxygen as they should. But the same with pulmonary hypertension. So we're looking for changes in PFT to tell us how your ILD doing, but also changes in the diffusing capacity, because that might help us think about, oh, I should now do some other testing for pH. So PFT is a really important part of how we monitor you with your ILD, but also how we monitor for possibility of pulmonary hypertension. Next slide, please. So the other test we do is a walk test. And I will say in our ILD clinic, we do a walk test for all of our patients at least once a year, sometimes more frequently, especially if they're on oxygen or their symptoms are changing. So the walk test is, you know, you have to walk for 6 minutes. We prefer to do it in a long corridor without carpeting and without barriers. It has to be a long, straight corridor, no curves, no corners. It's just one straight, long, uncarpeted hallway. And we measure the distance that you can walk. We have cones at our clinic that measures a certain amount, whether it's 20 meters or 30 meters. And we know based on how many times you walk between the cones, what your walk distance is. The walk test also gives us information about your oxygen level. What happens with activity? Is your oxygen level falling? And both these things are clues for pulmonary hypertension. If we notice that your walk distance is declining, so you can't walk as long as far as you used to, or we notice that your oxygen level is dropping more than it used to, or you're requiring more oxygen, these are things we look for as clues to pulmonary hypertension. Next slide, please. Next, I'm going to talk a little bit about NT-proBNP. This is a blood test. It stands for N-terminal pro-brain natriuretic peptide. And you're thinking, what does the brain have to do with this? That's just the name. It's not actually measuring the brain, it's measuring this protein. It's a protein in the blood. And the protein, NT-proBNP, is easy to measure in the blood. It's a fast test. Your insurance pays for it. The reason we test this is that it is actually a reflection of your heart function. So for people with PH, if it starts to affect your heart function, the level of this protein, NT-proBNP, will start going up in your blood. So it's a simple test we can do. We do it sometimes. Dr. Thenappan and his colleagues in the pulmonary hypertension clinic, they follow this regularly. So it's an easy test to do if we're thinking about pH. Next slide, please. Imaging. So this, I think, is also very important. So the PFT, the walk test, the NT-proBNP blood test, these are all sort of screening tests, but they don't make the diagnosis of pH. So I'm going to talk a little bit about imaging, because these are ways of actually visualizing the heart and the blood vessels. So it gives us another clue that pH might be present. So echocardiogram is an ultrasound of the heart. It's non-invasive, meaning we don't put needles in you, we don't poke you, there are no catheters. It's ultrasound, so it's non-invasive. But with the ultrasound, we can get a sort of an image of what your heart looks like. It also can give us an image of the pulmonary arteries, those blood vessels in the lungs, and it can suggest that those blood vessels are damaged or those blood vessels have pulmonary hypertension. So this is, I think, one of the most important screening tests for pulmonary hypertension. We order it all the time, and it's important, I think, to have an echo lab, a lab that does this test, that's experienced and knows how to get imaging in patients with different types of anatomy. The other imaging test I'm going to talk about is HRCT, high resolution CT scan of the lungs. As many or all of you know, for ILD, this is the way we make the diagnosis of pulmonary fibrosis. The CAT scan with high resolution can give us detailed images or pictures of the lungs. It can show us the pulmonary fibrosis. It can show us the pattern. But for pH, we also get other very useful information. It shows us a photo of the pulmonary arteries. And it can show us if the pulmonary arteries are too big. If they're too big, that makes us suspect that there might be pulmonary hypertension. So these are two of the imaging modalities we use to screen for pH if we're suspecting. And sometimes we'll see a patient in our ILD clinic, we'll get the high resolution chest CT, and we look at the CT scan images, and we notice that the pulmonary artery pressure or the pulmonary artery size is really big, and that sets us off on the journey to look for pH just by looking at the CT scan. Next slide, please. Okay, Dr. Thenappan, it's yours now.
Oh, thank you, Dr. Kim. So Dr. Kim went over the different methods of or testing modalities we have to suspect pulmonary hypertension. So all these tests are good, but what we call them as screening tests. So in medicine, like in practice, what we always do is do certain tests to screen whether you have a disease or not by first, before we go to a confirmatory test, if the confirmatory test is an invasive test. What do I mean by invasive test? It's a test which involves needles and going into the body to do it. So let's just take a step back. Your regular blood pressure is blood pressure in your body. We can easily measure that, right? You come to the doctor's office, primary care, any doctor, we put a cuff around your arm, we check the blood pressure, we know what your pressure is. So pulmonary hypertension is pressure within the artery in the lungs, not in your regular body, it's within your lungs. And as you can imagine, we cannot put a cuff around your lung from outside. So the only way to measure that would be to put a catheter in through the right side of the heart and into the lungs and actually measure the pressure. It's an invasive test, not a major procedure. It's not a surgery. It's like a dentist procedure. We do it under local anesthesia. So, but still, it's invasive, and we want to minimize any invasive procedure for the patient. So that's why we do all the battery of testing Dr. Kim discussed just a few minutes ago to see whether there is any hint or any concern for pulmonary hypertension. If all those tests comes back as negative, then we'll stop there because we don't need to subject the patient to an invasive test. However, on the other hand, if there is any suspicion on those non-invasive or less invasive screening tests, then we'll proceed to do a right heart catheterization, because right heart catheterization is the only way you can actually confirm the diagnosis of pulmonary hypertension. All other methods give a clue, and it's a surrogate. It's not an actual measurement of the pressure inside your lung arteries. So next slide, please. Okay, so what is a right heart catheterization? It's nothing but a catheterization of the right side of your heart. So we put catheters through veins, either in your neck or in your groin or in your arm. All these veins drain to the right side of the heart. We call this as all roads lead to Rome, like that all these veins in the body go to the right side of the heart. So we can take any vein, most commonly from your neck. If some reason that the vein doesn't work, then we go to the groin or the arm. From there, we just put a catheter through the vein into the right side of the heart and measure. This test is different from the usual blood pressure like we measure in the office, like I discussed before. Now, the third point I want you to understand, it's different from a left heart catheterization. A left heart catheterization is a catheterization where we cardiologists, we perform. We put a catheter not through the vein, but we put a catheter through the artery and go through the artery into the left side of the heart. And we do that to look at your arteries in your heart itself, called coronary arteries, to see whether they are open or blocked. Because if your arteries are closed, that's when you get heart attack or heart disease, like coronary artery disease. To check for that, we do the left heart catheterization. So, but for patients with pulmonary hypertension, we don't need to do a left heart catheterization. We do a right heart catheterization. Next slide, please. And I didn't mention that the cardiac catheterization is majoritarily done by cardiologists, but it's also done by pulmonologists at some centers who are trained to do this. So it's not like it has to be done by cardiologists. Okay, next slide. How is, how is the right heart catheterization performed? So it's an outpatient procedure. Patients can come and get this procedure done and go home the same day. So first point. Second point, the patient will be awake during the procedure. We don't give any general anesthesia. No tube in your throat or like IV sedation, nothing like that. Not even like a colonoscopy. Like, you come in, we just give a local anesthesia close to the vein. But just for discussion, take the neck vein. So we'll prep the area, clean it, and then we just give a local numbing medicine like a dentist would do. So then what we'll do is we'll connect you to the electrical monitors and to a system where we can measure pressure. After that, with an ultrasound, we find the vein in your neck, and then we put a IV in your neck vein. Basically, it's just nothing but a big IV. We call this as an introducer sheath. It's like the IV you get when you go into the hospital, nothing but a much bigger IV. We call this as an introducer sheath. That IV or the introducer sheath acts as a railroad or a pathway through which we can introduce a pressure measuring catheter. The name of that catheter is called the Swan-Ganz catheter. These are the two scientists who discovered this catheter approximately 50 years ago, like in Los Angeles, Swan and Ganz. Next slide, please. Maybe one slide if you go back. So you can see, next slide. Yeah, so like if you focus on the picture to your right-hand side, you can see that there is a green catheter that comes from the top, like this is the vein. We put the catheter in, and then the catheter comes in. It comes to the right side top chamber of the heart, and then through this valve, we take it into the lower portion of the heart, and then from the lower portion of the heart, we take through these arteries into the lungs called the pulmonary artery, where we measure the pressure. So we measure the pressure in the pulmonary artery, and that's the pressure we are interested in. If that pressure is normal, then we call this as patient doesn't have pulmonary hypertension. On the other hand, if the pressure is high, we define them as pulmonary hypertension. At the same time, since we are going through the heart, we can also measure the pressure in the right side of the heart. That gives us an idea of whether the right side of the heart is working well or not. If the right side is weak and it's failing, the pressure inside the right side of the heart can also increase. So we'll be able to find out. Number three, we also measure how much blood the heart pumps each minute. And a normal heart should pump around 4 to 5 liters of blood. And if your heart is weaker and it's not pumping enough blood, we'll be able to see that right away. So that's how we do the procedure. Now, normal pressures, like on the top portion of the right side of the heart, the normal pressure will be like 2 to 4 millimeters of mercury above the atmospheric pressure. The lower portion would be like 25/10. The pulmonary artery would be 25/10 with an average pressure or mean pressure of 15. We call it pulmonary hypertension when the mean pressure goes above 20. We can also take this catheter deep into the lungs and see what is the pressure on the left side of the heart. It's not important in patients with interstitial lung disease, but it helps us in some other patients with like heart disease and health. And then the last thing is how much amount of blood the normal heart pumps. It varies from person to person, how big they are. But if you adjust it to your body surface area, like for every body surface area, for one body surface area, one square meters, the heart should pump 2.5 to 3.5 liters of blood. And when you have severe pulmonary hypertension due to interstitial lung disease, and when your heart gets weaker, that decreases, and it would be less than 2.5. And next slide, please. So far we went over on how we diagnose pulmonary hypertension. We talked about screening tests, and if there's suspicion, we do a right heart catheterization to confirm the diagnosis. Then once we confirm the diagnosis, how do we take care of these patients? How do we monitor them? So it's always it's a teamwork. It's a teamwork between the pulmonologist and the cardiologist. We collaborate and take care of the patients. The pulmonologist will focus on the interstitial lung disease, because interstitial lung disease has different types of treatments that can be used to help to slow down the disease. And the cardiologist will work with the pulmonologist in treating the pulmonary hypertension on the right side of the heart. And typically, like, we see these patients like every 3 months in our clinic, and we make sure from a heart perspective, I'll speak for myself from a heart perspective, and Dr. Kim will discuss what she would monitor from a lung perspective. From a heart perspective, we see them every 3 months. We see how good their heart function is, and we can assess that by, and the pulmonary hypertension is, and we can assess that by listening to the patient's symptoms, by examining them and seeing them whether they have signs of heart failure. Because if they have heart failure, they have fluid buildup in their legs or in their belly, or their neck veins will show that, and their heart rate can be faster. They can be in an irregular heartbeat. Their oxygen can be low. Then we do blood tests. The NT-proBNP, Dr. Kim discussed earlier, that can go up. So we keep an eye on that and measure and see whether your heart is doing okay. Then 6-minute walk test, because the 6-minute walk test helps us to find out, are you feeling worse? It doesn't tell whether you're worse by your heart or lung, but it tells something is not right. If you're walking less and your oxygen is dropping, then we know, okay, something is just not right. Is it lung or heart? Then we figure out. We do an ultrasound of the heart. We do an ultrasound or echocardiogram to look at the heart function, not every 3 months, but every year at the least, and see, okay, is the heart size not getting bigger? Is the heart squeezing okay? And finally, we also go and do the right heart catheterization once a year after we start treatment to make sure that the pressure is not getting worse or it's getting better. I'll pass on to Dr. Kim.
So I just wanted to say that Dr. Thenappan and I work closely together, and we are so fortunate to have Dr. Thenappan and his colleagues at our center. I think it really helps us to screen for pulmonary hypertension and also to diagnose. So usually what happens is we'll see patients in the ILD clinic who have ILD, and we'll follow them very closely. We'll see how they're feeling. We'll ask about symptoms. We'll do a PFT, a walk test. And then if we suspect PH, we'll do some of those screening tests that we talked about, an echocardiogram. We do a PFT and walk test routinely, sometimes the blood test, the NT-proBNP. If anything suggests to us that the person might have pulmonary hypertension, we send them to Dr. Thenappan or one of his colleagues, and then they take it from there. They do a right heart cath. If the patient has pulmonary hypertension, they start treatment. And I will say, I think we're very fortunate to have Dr. Thenappan and his colleagues. I think it's been so helpful for us to have a pulmonary hypertension group at our center that we can work closely with. And I know some centers, unfortunately, don't have that. So we work very closely together. We follow our patients closely. Dr. Thenappan follows the PH patients closely. And some people might think, well, you know, isn't that just a lot of doctor visits? And I feel like the more eyes on you, the better. We do focus on different things. but we both also focus on the person and how are you doing and what we can do to make you feel better. So even though I focus on the lungs and Dr. Thenappan focuses on the pulmonary hypertension and the heart, I feel like both of us, both groups, really have the same goal, which is how is the person doing and what can we do to help you feel better, or maybe improve your quality of life or maintain your quality of life. So I feel like we work very closely together, and that's fortunate. We follow the patients, we screen, and then we send them to Dr. Thenappan and his group to do the right heart cath, to make the diagnosis, to monitor the pulmonary hypertension and treat the pulmonary hypertension.
No, thank you, Dr. Kim. I completely agree with you. Like, it's the patient as a whole. Like, both team works together and makes the patient feel better from whatever aspect. And I think you very nicely, just summarize that. And I always tell the patients who we are involved in their care is it's a combined approach helps, because there's no cure for this disease at this point. And we try to optimize as much as possible. Like the cardiologists optimize the heart part of it, and the pulmonologists optimize the lung part of it. So at the end, the patient can get each and every little bit of benefit they can from the therapies we have. I think we'll stop there and take questions, I guess.
All right, thank you guys so much. That was a really wonderful tour through all of this complicated information. We do have time, checking my clock, for some questions. I will remind everyone, if you want to go to your control panel and submit any questions for our experts here. We would love to try to answer as many as we can. I'm going to start with a topic that has come up in several of our submitted questions, and that is, do all patients with ILD or pulmonary fibrosis just eventually develop pulmonary hypertension during the course of their disease? Is that sort of, you live long enough, you end up with pulmonary hypertension type of situation, or is it more a percentage of and certain risk factors and things like that? Maybe Dr. Kim, I'll let you start with that.
That's a really good question. And the answer is no. Not every pulmonary fibrosis patient will develop pulmonary hypertension. In fact, it's the minority. And so this is why we really focus on screening and asking questions, and sometimes doing the screening test. So it's fortunate that not every PF or pulmonary fibrosis patient will develop pulmonary hypertension. It's difficult to know who will. We do know, for example, that some people with ILD have connective tissue disease or autoimmune disease, and those patients have an independent risk for getting pulmonary hypertension, so we pay very close attention to them. We do know that there are certain perhaps types of pulmonary fibrosis that have been reported, that association with pulmonary fibrosis and pulmonary hypertension, like IPF. We also know that some people with pulmonary fibrosis also have emphysema, and we call that CPFE. And we know that that specific entity, CPFE, also has a risk for pulmonary hypertension. So the answer is, fortunately, not every pulmonary fibrosis patient will get pulmonary hypertension. It's difficult for us to know, to tell you, you're going to be one of the ones who will get pulmonary hypertension, or you will never get pulmonary hypertension. We just don't have that data yet, but there's a lot of research in that area. So for now, the best we can do is follow you very regularly and see how you're doing. What are your symptoms? Is there anything to suggest that we need to start screening for pulmonary hypertension? Dr. Thenappan, what would you add to that?
No, thank you, Dr. Kim. I think you very nicely pointed out all the bullet points. The severity of, there has been studies looking at, is there a relationship between severity of lung disease and pulmonary hypertension? But interestingly, there is no clear relationship. One would think if you have a severe ILD, and you have compromised lung function, you're at risk for pulmonary hypertension, but really no, there's really no. So we don't have a clear picture of why some patients develop this and not. Is it genetics? Is it comorbidities they have, like other problems? Is it the low oxygen level that predicts? The only thing is, like, if you take people with all ILD, like I agree with Dr. Kim, only a minority of patients develop it. But if you take interstitial lung disease patients who are listed for transplant, 50 to 60% of them have pulmonary hypertension. But it's a difficult thing to figure out because they may be listed for transplant because they develop pulmonary hypertension, right? So it's a very challenging puzzle to solve. I think the short answer is, fortunately, as Dr. Kim said, only a minority of patients. We just don't have a clear picture of who's at risk, hopefully in the future, so that we can screen them, identify them early.
Thank you. I'm glad you brought up the incidence in transplant. I think that's one of the clarifying issues for me, is that it's certainly not everybody, and it is definitely multifactorial. And I think there's so much more to understand, because you're right. If you look at a population of people who are being listed for transplant, it's not 100% that have pulmonary hypertension. Arguably, they would be the more severe group. So we have another question here. Dr. Thenappan, I'm gonna send this one to you. If pulmonary fibrosis, and this, I think this reflects back to some of the things we talked about during our last session, if you could briefly cover, but if pulmonary fibrosis is the cause of pulmonary hypertension, why is it that some people can have pulmonary hypertension without having pulmonary fibrosis?
Oh, yeah. So pulmonary hypertension is like, I think I discussed this in the last session. It's like fever. Fever can be due to many different things, right? In your body, you can get fever because you get a toothache, you get a lung infection, you get a urinary tract infection. Like this, pulmonary hypertension literally is high pressure in the lungs. Many different things can cause high pressure in the lungs. The most common is actually left heart problems. If your left side of the heart is not working well, like there's a valve problem in the left side, or the heart is weaker on the left side, that causes pressure in the lungs to go up. So that's pulmonary hypertension, left heart disease. The second most common cause is interstitial lung disease, or COPD, lung disease. Then it can also be due to blood clots. Sometimes patients get blood clots in their legs that go into the lungs that can cause high pressure. Then rarely, a rare type of pulmonary hypertension is due to autoimmune diseases like scleroderma, or genetic problems, or HIV infection, or liver problems. So pulmonary, the blood vessels can get thicker and the pressure inside your arteries can go up for many different reasons. And interstitial lung disease is one of the reasons, if it makes sense.
That's a great answer. Thank you. Another question that has come up, and I think this is a really insightful one, actually, and it gets a little outside of diagnosis, but it's about, if I do have pulmonary hypertension related to my ILD, can I exercise? Is it safe? What should I do? And I'll let both of you kind of
Sure.
give a little insight on this.
Yeah, so maybe I'll take the first crack. I think it's very safe to do exercise, like as long as the oxygen level is maintained above 90%. Like low oxygen level is not something that we want, because low oxygen level is adding fuel to the fire, right? It's going to make your pulmonary hypertension worse. So if you're on adequate oxygen during exercise and you're able to maintain the saturation more than 90%, exercise otherwise has shown to be beneficial. It's beneficial for your musculoskeletal system. It actually keeps you in shape because of that. Psychologically, it helps you, and it also improves your exercise capacity. And what research has shown us is, like, we have many drugs for pulmonary hypertension, not, all types of pulmonary hypertension. For pulmonary hypertension due to lung disease, we have one type of treatment. Exercise alone improves your walk distance more than what these drugs can do. Right? So the benefit from the exercise is it's much more than what the drugs can do. So I think exercise is important, it's advised, but we have to do it within our limits. We have to make sure your oxygen level is adequate. And I always tell my patients, called symptom limited exercise. You listen to your body. If your body says stop, stop, take a breath, and then go. Don't push yourself too much. And I'll have Dr. Kim pitch it.
That's excellent, Dr. Thenappan. We also completely agree with that. Exercise is so important for our patients with ILD. And I tell my patients, the best thing you can do is to move, walk, or do whatever you like to do. When patients have both ILD and pulmonary hypertension, they tend to be more short of breath than if they have one or the other. And they also tend to use more or need more oxygen. So when they ask about exercise, or before they start an exercise program, I always recommend they start with pulmonary rehab. And that's because in pulmonary rehab, they're monitored closely. Their oxygen level, their oxygen saturation will be monitored, their heart rate. And so it's a safe way of starting exercise. They'll help you get stronger. They'll help you increase your exercise level. They'll be able to tell if you need oxygen, how much oxygen should you be on. And it sort of helps you figure out your limits. How much can you push yourself, but in a safe way? Because as Dr. Thenappan mentioned, we don't want you to exercise and have your oxygen level go really, really low. We want you to exercise. We want you to do it regularly, but we want you to do it safely. And so I do recommend pulmonary rehab for all our patients because it's a safe way to start exercise if you're not exercising. And it helps you, and helps us and your doctors figure out how much exercise you can do, and also how much oxygen you need, and to exercise safely. And I think that's the key. We want you to exercise safely.
That's a great answer. And I do have a follow-up question to that. So beyond, with pulmonary hypertension in particular, I know there are some additional symptoms that can happen, such as getting dizzy or even passing out. Are there other warning signs or limitations in terms of exercise? You mentioned having excessively low oxygen levels that we should try to avoid or either correct for or slow down to prevent. Are there other things that people should say, you know what, that might be too much exercise for me right now, and I should, perhaps talk to my doctor about, what to do about that?
Yeah, that's a good question. So generally, I think oxygen level is one. Number two is symptoms. And as you said, patients can feel dizzy or feel like they're going to pass out, or sometimes they pass out because their heart is not able to keep up with the amount of blood the body needs during exercise. So if they feel any of those symptoms during exercise, like lightheadedness, like near pass out like symptoms, or chest pain, they should stop. I think they should not do that. Other than that, if somebody is obviously like a lot of fluid, like build up in their body, and they are like what we call as heart failure, worsening of heart failure, probably that's not the best time to do it. You get the fluid off, make sure you are stable before you start exercising. The general question people ask is, oh, my heart rate goes up. Should I worry about it? Like, at what time we want? It's not uncommon for your heart rate to go up. There is no one magic number. We tell the patient, okay, beyond this, if your heart rate goes up, stop. We just go more by symptoms rather than just by the heart rate. Majority of the patients with PH and ILD, their heart rate will go up because their oxygen levels are lower and the heart is weaker. So the heart is trying to keep up. As long as they're feeling okay, they're not having chest pain, they're not lightheaded or dizzy, I think it's okay.
Great answer. Thank you so much. We are at time for our session today, and we still have, I wish I could get to other questions. These are really great, but I want to just pause here and thank everybody for their time and attention today. Thank you so much, Dr. Kim, Dr. Thenappan, for being here. These have been just 2 really wonderful hours of information on a topic that's challenging and complicating even for healthcare professionals. So to provide this information to our community has just been really, really helpful and beneficial, I think. I'd also like to thank United Therapeutics for this industry sponsored webinar. And if you that are listening out there would just at the end of this session, take the opportunity to give us some feedback about our webinar today. We would really appreciate your insights. I hope everybody has a great rest of their day, a wonderful holiday season, and we'll see you in the new year. Thank you all so much.